Okay, welcome to everyone. MD Anderson Cancer Center Integrative Diagnostic Medicine Case Conference. We are back, 7/24/2020. Let me make a brief comment about the last 2 or 3 weeks. Some people were complaining that the WebEx link didn't work. There was no conference for about 2 or maybe the past 2 or 3 weeks. It was transition in July. You should receive a new invitation, not the old link for each conference. Second thing is we have had our issues with designating co-hosts, etc., to squelch microphones. We're working on that, and I hope that we will be able to perfect it. At any rate, it's a work in progress. Watch for updates. So without further ado, this is a great way to get your weekend started. We always start with a warm-up. So let's go with a warm-up. MRI warm-up first, and here it is. I'm going to give you a second to study it. Remember, you can use the chat function. Anybody in differential diagnosis? I think that's the, here we go. Differential diagnosis, and see if there are any ideas for differential diagnosis. Okay, I will go first. Pituitary adenoma, specifically macroadenoma. Any other ideas? How about other primary tumors of the sella suprasellar region, such as pituocytoma, granular cell tumor? Remember this little group, small group of 3 tumors that show nuclear TTF1 positivity? They have had different names in the past. Probably, I'm pretty sure, in the new 5th edition of the World Health Organization, they will all be consolidated under pituocytoma. All right, Dr. Harb says meningioma. Absolutely, intracellular meningiomas happen. This does not look like a tuberculum. It's really cellular, supracellular, not tuberculum like we covered a week or 2 ago, but intracellular is good. Okay, why don't we have a look at the histology? Everyone ready? This tumor was resected. Here's the histology. Interesting, no? What do you think? Typical pituitary adenoma? Any thoughts? Okay, this is the one crazy thing about Zoom and WebEx and all of that is depending on the chat function, you know, a lot of people don't want to, it takes too long to type, etc. All right, Dr. Harb says renal cell carcinoma. You mean metastasis of renal cell carcinoma to the cella suprasellar, mimicking a pituitary macroadenoma? Okay, I'm sorry, did I show you this image? I may have, oh, sorry, my bad. Yes, that is exactly correct. Dr. Harb has nailed it. This is metastatic renal cell carcinoma to the cella. This patient had multiple metastases, some of which had been removed. The question was what to do with the cellular suprasellar, and it was resected. And as you can see, classic clear cell renal cell carcinoma. Okay, I agree. I did not give you all the information, but you have to be suspicious, and kudos to Dr. Harb for including metastatic metastatic carcinoma in the differential. Always remember metastases, even if the patient doesn't have a history. Metastasis from unknown primary definitely occurs. Virtually any systemic malignancy can present initial presentation with a brain metastasis. And in some cases, it can be very difficult, even on CT chest, abdomen, and pelvis, and whole body fused PET CT scan to identify the primary. So always keep that in your differential diagnosis. Okay, and again, that's a pretty good example of a pituitary macroadenoma mimicry. All right, let's do a second MRI warm-up. MRI warm-up number 2. All right, now we're actually going to start with the histology first, then we will go to the imaging. All right, and I'm going to give you a special favor here. Pay attention. All right, the reason why you want to pay attention is after I show you the histology, I'm going to ask you 3 questions. All right, everyone ready? You're paying attention. You're not multitasking. All right, here we go. I have about four H&D slides to show you. The histology first. You should be analyzing this, thinking about the possibilities. Second H&E, give you a minute, study it. Third H&E, Have one more H&E. All right, here it is, the last H&E. All right, everybody got it? Enough time? Ready? All right, you paid attention, didn't you? Here we go, 3 questions. Ready? First question, what classic neuroimaging sign did this tumor display? See, when an oncologic neuropathologist looks at histology, they do not see only histology and molecular signature and differentiation markers. They see pre-op imaging, and that's what you need to do. All right, Dr. Harb, eggshell calcification, that's a very interesting guess. All right, Dr. Perez, and I know Dr. Perez is not familiar with the case, all right, says sunburst pattern, and Dr. Perez is correct. All right, and so one of the keys here is you can't be familiar with the cases, right? That is perfect. All right, question number 2: which classic histologic feature does the tumor display? And I'm going to put it what classic histologic feature. I'm going to give you a minute to chew on that. Chewing. Classic histologic feature. Okay, and okay, Dr. Min Wang, expert, Peterburger trained oncologic neuropathologist. Dr. Wang says whorls. That is correct. However, note, not whorls. In other words, this tumor definitely is a transitional meningioma. There are whorls, but that's not what I'm going for. Did you notice at the beginning that I said pay attention? Have I ever done that? No, that must mean that it's not a 101. Right? It's not a 101. Maybe it's a 201 or a 301, maybe even graduate level, maybe even faculty level. Did you see any other interesting histologic feature? Anything catch your eye? All right, Dr. Harb says, can we see the path again? Well, of course you can. Also, here's another question. What unique among meningiomas immunophenotype does the tumor display? So among meningiomas, meaning even among meningiomas, this particular subtype has a unique feature, okay? Immunophenotype. All right, let's take the imaging sign first, and then I will show you the histology. It's coming up again. But see, listen, here's the thing. I want to give you a second shot at the histology, but in life, oftentimes you don't get a second shot. That's why you cannot look at a slide and say, oh, hyperostotic meningioma, and then you see whorls. Oh, meningioma, I'm done. When I say pay attention, and you're about to say one of the 3 classic meningiomas, third graders can diagnose transitional meningiomas with whorls. I wouldn't say pay attention for the whorls. There has to be something special when I say pay attention. Now, hopefully in life, when you're dealing with real patients, real lives, that you are paying attention. You don't make a snap diagnosis and then move on. Next case, next case. You must always question your hypothesis, okay? All right, so that's hyperostotic meningioma, and Dr. Perez, Alex Perez, neuropathology fellow, now at MD Anderson for 4 months, hair on end or starburst sign. For those unfamiliar with the imaging, here it is. This is a greater sphenoid wing meningioma, spheno-orbital meningioma. It's involving 3 different anatomic compartments. We see a fair number of these at MD Anderson Cancer Center. All right, here it is an axial view, and this is bone windowed, and you can see the jagged edges. And this is probably the best, the coronal of the 3. And again, as you look along the margin here, you see the little spicules of bone, hyperostotic bone. It's actually extending into all 3 compartments. That is the hair on end or starburst sign. All right, how about this? What classic histologic feature does the tumor display? You ready? All right, just for Dr. Harb, I'm going to give you another shot at it. Okay, here it is. This was the last. This was the fourth H&E that I showed you. Had you already just written the thing off as a transitional meningioma and you stopped looking and you thought, well, why would I want to look at the 4th H&E? I've already seen enough. And this is what we do as pathologists and as diagnostic radiologists, diagnostic imagers. This is what we do. We look at one image, we look at one facet, we make a snap judgment, and then we go brain dead. We think, I don't have to look anymore. I don't have to look at any slide. All right, one of the pathologists, look at this and tell me what it is. Yes, Ashley Holloman, thank you. Secretions, they have a name. What's the name of those secretions? Dr. Harb, pink globules. What is the name of the pink globules? The pink globules, the secretions have a name, and that is what it is. All right. Sergio Pino Oviedo, all right, former MD Anderson fellow, now expert hematopathologist and half neuropathologist, says pseudosamoma bodies. Kudos, Sergio. All right, circled are the secretions. Now, it's a good eye to pick them up. The question is, do you know what a pseudosamoma body looks like? All right, these are pseudosamoma. They're not samoma bodies. They are protein secretions in the cytoplasm. And the name, yes, the name of this tumor. So what's the name of the tumor? What's the name of the subtype? The hallmark feature is the presence of pseudosamoma bodies. And the type is secretory meningioma. That defines it. All right. How about this one? There. You see the yellow circle? All right. Nice, huh? All right. Secretory meningioma. Now, this is very typical of secretory meningiomas. It's not in your face. It's not like the best Peter Berger textbook illustration with labels and circles and arrows. All right. As the legend, Dr. Lawrence Ginsberg, head and neck radiologist, MD Anderson Cancer Center, says, you know, these diagnoses are a lot more difficult to make when the scans do not come with arrows and circles and annotations. And that is true. You are going to have the eye for detail. And looking in a meningioma, to look for pseudosamoma bodies in every single case you see is something that you should do. That is attention to detail. All right. Now, I'm sure this is what you wanted. Am I correct? This is a different case. This is a drop dead gorgeous secretory meningioma with a very high pseudosamoma body burden. Right, but that's not what you're going to get. Most of the time, you're going to have to pick it up, the eye for detail. Of course, the more you see, the better you get. And if you get burned, if you totally miss this, that's a good thing. That's not a bad thing, because it should be a lesson to you. And you could say, well, wait a minute, it's not fair. I didn't have the slides. I couldn't go up to 40X, and I actually have a high drive 60X, X600. Yeah, in life, you're not always going to have that luxury. So we are simulating real life when I only show you one field, and I will not ask you to see something that's not there. Okay. All right. This was the last question. What unique among meningiomas immunophenotype does this tumor display? There's one unique marker that we always stain for that only secretory meningioma displays. Which marker is it? All right. I'm gonna wait just a second. See if someone wants to fill. There you go. Giselle Lopez at Duke. Yes, CEA. Ashley Holman, CEA. That's exactly right. Carcinoembryonic antigen. Good job. Now, the cells, the subpopulation of cells in secretory meningioma, which are producing the pseudosamoma bodies, those cells are also strongly positive for keratin and strongly positive for EMA. Now, we use EMA all the time as a marker for meningioma. It's a relatively poor, weak, often focal marker for meningioma. But in secretory meningioma, those cells, the ones that are producing the pseudosamoma bodies that are CEA positive, are 4+ strongly positive for EMA and for keratin. So they light up. And that's good to know. Okay, guess what? I'm giving, for everyone who did not spot the pseudosamoma bodies and didn't think to guess hyperostotic meningioma and heron end or starburst or sunburst sign, I'm going to give you a chance to redeem yourselves right now. There's a bonus question for this case. Ready? Here we go. What is the recurrent molecular alteration that characterizes secretory meningioma? It has a very distinctive and unique molecular alteration. Many different meningioma subtypes, especially the more aggressive ones, show specific molecular alterations like BAP1 alteration. That will be an aggressive meningioma. Loss of H3K27 trimethylation mark characterizes a small population, maybe 5% of meningioma is more aggressive. Secretory is not more aggressive. The other question I could have asked is what is a relatively unique imaging presentation of secretory meningioma? Not the hyperostotic variety necessarily, just regular dural-based Gordon variety. And the answer would have been marked vasogenic edema in the adjacent brain out of proportion to the size of the secretory meningioma in the absence of brain invasion, right? Secretory meningiomas tend to do that. But I'm asking molecular alteration. Anyone? Okay, we're not going to dwell on it. Here it is. It's actually a twin. Yeah, good. Giselle Lopez, right? Duke neuropathology fellow. Yes, it's actually the combined KLF4, specifically the point mutation K409Q and TRAF7, the combination highly characteristic of secretory meningioma. Very good. Okay, tell you what, I think we're kind of getting sleepy. It's Friday. Everyone needs just a little bit more time to warm up. So let's go to, how about a histology warm up? Does that sound good? All right, we'll start with imaging. Since on the imaging warm up, we started with histology, why don't we start with imaging for the histology warm up? All right, well, turnabout is fair play. And since in this conference, this is the Integrative Diagnostic Medicine Case Conference, and we treat imaging and histology and molecular signature as the same. It's one field, different aspects, and all of us, whether pathologists, radiologists, molecular biologists, hearts in the lab, hearts in the clinic, we all need to speak the same language and know this. All right, have a look. Has anyone spotted the lesion in question? I'll sit showing the imaging first. I'll give you a second just to see if you can spot the lesion. And then, as we always do in this conference, because we have such a wide range of expertise, let's circle it here. You can see the lesion down there, posterior fossa. Appears to be a dura-based mass adjacent to the brainstem, actually near the exit of the hypoglossal nerve. There's the medulla. All right, everybody got it? All right, so that's just the pre-op imaging. All right, this is histology warm-up. And I tell you what, why don't we do it like we do it in real life with histology, say at frozen section, not for the outside case. Well, outside cases, they have it. Let's start with cytology, the smear. Imagine that you have this case at frozen section. Let's simulate it and let's look at the smear first. Here it is. That's the smear. Differential diagnosis. And I will, I'm gonna wait just a second here. A little bit of time, have a look at it, analyze it. And I know a lot of people have to be poor typists like I am. I type with one hand. Actually, I can use the other hand to work the space bar. It's not that bad, so I type with both hands. All right. Any ideas? Differential diagnosis? Just one thing, you know, that sort of thing. Melanoma. Dr. Harb, melanoma or plasma cell. I love melanoma. I love melanoma. It's epithelioid, and look at the range of size of cells. You want to go higher power? Here we go. Absolutely. Melanoma has got to be probably #1 on your list. Look at these cells. Now, this is meninges. Meninges, posterior fossa. Is there a particular melanotic tumor that loves to grow in the posterior fossa? What's the name of that tumor? And the answer is melanocytoma. Good. Dr. Harb got that one. Question. Listen, question. What is wrong about the imaging for melanocytoma? Where does melanocytoma originate? We've already said posterior fossa, absolutely. Posterior fossa, cervical, spinal canal. What's wrong is this appears to be a dura-based, if you will, tumor, not adherent to the brainstem or cervical cord. Melanocytomas originate from normal leptomeningeal melanocytes in the pia. And what they do as they grow, they follow the blood vessels of the vascular pia arachnoid into the brainstem parenchyma or into the spinal cord parenchyma along the perivascular vertical roband spaces. This tumor is not doing that. It's more peripheral. Okay, I just want to point that out. The anatomical location is good as far as the posterior fossa goes, and it's good as far as extra-axial origin goes. It's good, but it's not good in terms of being dura-based rather than pia-based, if you will. Now, that is the level of sophistication that you need to approach these cases, okay? All right, other ideas. I've got melanoma. You want to move on to the histology? Okay, here we go. This is a histology. It beautifully reflects that smear preparation. You like it? Typically with smear preparations, we say there's really, or with cytologic preparations, but specifically with smears, there's only two patterns, single cells and clumps. And the clumps are either due to cell junctions like desmosomes in carcinoma or intertwined cell processes such as in schwannoma or sarcomas, or both desmosome cell junctions and intertwined processes in meningioma. That's clumps. Single cell would be things like melanoma, lymphoma, central neurocytoma, etc. All right, what you see here, very epithelioid population of cells, I'm looking very hard, and I can tell you there was no discernible melanin pigment on H&E. Does that militate against melanoma? The fact that there's no discernible cytoplasmic melanin? Absolutely not. Yes, Dr. Harb says no. All right. Thank you, Dr. Strella Perez. No, it does not. I would say this. I would say that Dr. Wang Min Wang came up with a good one. I'll address in just a second. Approximately 2/3 to 3/4 of metastatic melanomas are amelanotic with respect to H&E. There's no melanin. So that will not help you. Probably more than not, over half have no melanin. Okay, Dr. Min Wang came up with an excellent differential diagnosis. It's dura-based, rhabdoid meningioma. What does rhabdoid meningioma look like? Well, I'll tell you one thing, it doesn't look like rhabdoid meningioma. Now, I know you're going to say, well, I see pictures in the textbooks of rhabdoid meningioma that just shows denser pink cytoplasm and an otherwise garden. Yes, and they're labeled rhabdoid. Yes. All right. And guess what? Those tend not to have bad behavior because they don't have element mitotic activity, et cetera. Rhabdoid meningiomas, which are really the bad actor, all right, the grade 3, that's anaplastic, i.e. malignant meningioma, look rhabdoid like this. They're rhabdoid. Now, maybe these are a little bit large. That's why I chose the term epithelioid rather than rhabdoid. But yes, so kudos to Dr. Min Wang. Now, again, Dr. Min Wang is a very highly experienced oncologic neuropathologist trained just like me by Peter Berger. I was in the Duke era. Dr. Min Wang is very young. He is in the Hopkins era. Okay, how about molecular signature? I'm going to give, this is, anybody want to take a guess on what this marker is? All right. Dr. Harb, SOX10. I like that guess. All right, I've got SOX11. All right, from Sergio. All right, it's nuclear. All these are good guesses. All right, Sergio says, sorry, mistype, SOX10. Good job. Okay, it's P10. Does it help you? The answer is probably no. Why? All right. Do you know what? Does anyone know what the P10 is the name that won, if you will. P10 was co-discovered at MD Anderson Cancer Center. I know many of you who attended this conference for more than a year. No, I talk about this every opportunity I get. P10 was co-discovered at MD Anderson. What is the, we'll ask this. This is a great question. What is the MD Anderson name of P10? What did our discoverers give it? And this is the late Dr. Peter Steck was the primary driver, PhD in the Neuro-Oncology department, of the discovery of P10. This is not the name he gave it. And by the way, the neuropathologist co-discoverer with Dr. Steck was Dr. Lauren Langford. All right, neck and neck, papers came out virtually simultaneously, and P10 simply predominates. Anybody know? Because it's relevant to, yes, Sergio. Yes, MMAC. Originally it was MMAC1, and I think he dropped the 1. Now, here's where the rubber meets the road. What does MMAC stand for? And the reason why I'm going through all this is I asked initially, does it help you to know that this tumor is overexpressing or, P10, a P10, player? And the answer is no, because it is one of the most common altered genes in cancer, in all cancers. MMAC, 2 M's, stands for mutated in multiple advanced cancers. Mutated in multiple advanced cancers. That is a great name because there are so many different cancers in which it's mutated. All right, so I just wanted to throw that out. All right, would you like another immunostain? Let's go with cytoplasmic this time. Here's a cytoplasmic stain. This gives you the answer. Once I show you what this stain is, we are done. All right, Dr. Harb, Zainab Harb, MART1, HMB 45, we're going for melanoma or melanocytic. I don't know how many people saw the mitotic figures. There were a lot of mitotic figures. I didn't dwell on it. On the smear, you can see including atypical. All right. Okay, it is not a melanoma marker. This tumor is not a melanocytic tumor. It's not a melanocytic tumor. Remember, a differential diagnosis is always more than one thing. Melanotic rhabdoid meningioma. Honestly, I've never heard of that. Melanotic schwannoma, I've heard of that. No, melanotic rhabdoid, I've not heard of that. So I think we got to come up with something else. Think about it. You have a differential diagnosis, and I'm telling you, once I show you what this marker is, Okay, I'll give you an additional hint. It is not a molecular signature surrogate. All right, metastatic carcinoma, I like that from Dr. Harb. Thank you for putting in metastatic carcinoma. Epithelioid carcinomas frequently are epithelioid. Can they be disrhesive? Sure. Breast cancer oftentimes will be disrhesive, for sure. All right, so that would have fit with the smear. That fits with everything. You say, well, wait, the smear was more single cells. They weren't. That the breast cancer can do that. Other adenocarcinomas can do that. All right, I'll tell you, this is not a molecular signature surrogate marker like P10. It's a differentiation marker, like HMB45, Suxin, et cetera. Is. It's a differentiation marker. What is your differential? What do we call this tumor? At the very beginning, what do we call it? And when we described it histologically, the cytology, did we say it was a spindle cell tumor? No, what do we call it? Did we call it an epithelioid tumor? Is there anything else in your differential for epithelioid tumors other than melanoma and rhabdoid meningioma, an atypical teratoid rhabdoid tumor? Is there any other epithelioid tumor? What's your differential diagnosis for epithelioid tumors? Come on, pathologists. Angiosarcoma. Oh, that's a good one. Okay, Dr. Harb, Zainab Harb wins. Glioblastoma. This is GFAP. Epithelioid glioblastoma. Why didn't someone say that sooner? Was it the imaging? Was it this? You have to generate a differential diagnosis, right? Based on, remember the eight spheres of 8 data spheres, this particular model, all right, which I'm very big about promoting. Each one is standalone. So you create a differential diagnosis, meaning multiple, 10 things at least for this extraaxial, apparently dural-based mass, including meningioma would be there, metastasis would be there, yada, yada, yada. Okay, then once you see the histology, once I showed you that smear and you saw it was epithelioid, you don't use this data yet. You formulate the differential for the smear by itself. Then in Venn diagram fashion, you overlap them and you come up with possibilities. Okay. Now, if you had done that, if I had showed you, for example, the smear of an epithelioid tumor first, perhaps you would have put, I'm sure someone would have said epithelioid glioblastoma sooner, but you're being biased already. All right. You fix your hypothesis by knowing the imaging, et cetera. And the same thing can happen with molecular signature, et cetera, et cetera. Someone explain this to me. What's going on? Tell me the story of this patient. It's very simple. It's a very simple story. What's going on? Are glioblastomas dura-based? No. I mean, typically, no. No, they're not. How do you explain it then? How do you explain this glioblastoma in the subarachnoid space? Any explanation? I'm sorry, did I show you this scan? I can't remember. Was this the first scan? Oh, that was mean. Yeah, it's a drop metastasis. Yeah, it's a CSF drop metastasis from epithelioid glioblastoma. How do you like that? Okay, was that mean? What Dr. Horowitz actually likes it. Okay, here's the thing. I have said this on many occasions. If you think that was mean, I'm telling you, I cannot be meaner than nature and cancer will be to you out there in the diagnostic world of diagnostic imaging and surgical pathology. I tell you, it's out to get you, for you to fall in the pitfall, fall in the trap, and that's why you have to sharpen, all right? Sharpen your wit, sharpen your powers of observation, be skeptical. Don't jump to a simplistic diagnosis. If you do, I guarantee you, when you're in charge, 8% of your diagnoses will be wrong. You will miss things, you'll hurt your patients. If you're not skeptical to the very end, use the 8 Venn diagram spheres. Okay, you like that? Okay, that was good. It was fun for me. I can tell you, epithelioid glioblastoma, you will see examples that are even better than this. This has a little bit of fibrillarity. You'll see examples where they are perfectly smooth, spherical cells, exactly like metastatic amelanotic melanoma. You always have to keep glioblastoma in mind. Okay, I will tell you this. I have to tell you the reason why I admire, one thing I admire about Dr. Ginsberg, Larry Ginsberg, he frequently at his conferences presents cases where he made a mistake or he missed something. He does that all the time. Now that is someone who has a huge amount of self-confidence to be able to do that. And if you can't admit that you are fallible, you make a mistake, etc., you're going to be in big trouble. All right. Did I ever miss an epithelioid glioblastoma? Oh yeah, I missed it big time. And I missed it big time in a frozen section talking to Dr. Jeffrey Weinberg, one of our excellent neurosurgeons. This was the situation. There were two tumors, right? Two enhancing tumors, right frontal lobe, left parieto-occipital lobe. No contrast enhancing, no connection by T2 flare, no connection by CSF pathway. Has to be metastasis, metastatic carcinoma, metastatic melanoma, etc. This is what the smear looked like, even better than this. At frozen, Dr. Weinberg, who is one of the neurosurgeons who frequently scrubs out, comes into the frozen section suite to look at the path, loves to see the path. We're looking at it. I'm seeing these epithelioid cells, and I'm telling him, I don't know if it's epithelioid carcinoma or melanoma. And Dr. Weinberg, I remember this like it was yesterday, said, but it's not glioblastoma. And I said, right, it's not glioblastoma. So the next day, the permanent sections come out. It's glioblastoma. It's a multicentric glioblastoma. Absolutely. We published it. It's a pitfall. It's absolute pitfall. Do you think I'll ever fall or have fallen into that trap again? That had to have been 15 years ago, 20 years ago. No, never fell into the trap again. Why? Because I got burned. And that is the best teacher, but you don't want to get burned like that. And now in this particular case, there were no adverse consequences to the patient, but there could be in some instances if you make the diagnosis. Okay, hence the point to stay on your toes. All right, and again, there you go. Epithelioid glioblastoma. Everybody got it? Okay. Okay, I think we're warmed up. We're ready for patient, ready for patient number one. I think I only have one patient. I've taken half the time to warm up, so it's just as well. But this is an important patient. Now, let me say this right off the bat. This patient has been presented already twice. The first time I saw it was in Dr. Sanjay Singh's Neuro-Radiology Imaging Conference. So Dr. Singh, senior Don neuroradiologist of the Texas Medical Center, conducts the conference every couple of weeks or so. This case came from one of the hospitals at which he practices, and he presented it. The patient subsequently came to MD Anderson Cancer Center, where a second surgery was performed, and that's how the case is emerging in this conference. And it was shown at Tumor Board. So most of the MD Anderson attendees to my conference today will recognize the case, but that doesn't mean that you still might be able to take something away from the exercise of going through it logically. Okay. Now, don't let any of this bias anyone who doesn't know the case doesn't know what I'm talking about. Here we go. 46-year-old male. The point of this case is that imaging is pathology. It is pathology, and I'm telling you, it is still an uphill battle in my world of oncologic neuropathology to get even oncologic neuropathologists to buy into this, that they should be examining the scans themselves and learning from the experts, the neuroradiologists, et cetera. Imaging is pathology. Here we go. All right. Now, I know, again, if you are familiar with the case, either from Dr. Sanjay Singh's conference or from the MD Anderson Tumor Board, I would ask that you not chat because others will see that. For everyone else who doesn't know the case, I only have one question. What's your diagnosis? Yeah, diagnosis. Now, we know that it's always a differential diagnosis. Hardly anything is ever pathognomonic. I'm just go ahead and say, nothing's pathognomonic. Pathognomonic, not mnemonic, not run by air, pathognomos, knowledge, pathognomonic. This imaging is highly suggestive of a very specific tumor type because of its morphology. This is like looking at an H&E. It's like looking at an immunostain. This mass has specific morphology, and it is telling you an important location. And here's the key. The key is, what is the precise anatomic location of the mass? All right. Again, for those who are not familiar, I know we have probably some general pathology residents attending the conference, etc. This is the region that we're talking about. Okay. Now, the next question I'm going to ask you is, what specifically, listen, what specifically are the features indicated by the arrows? There's a yellow arrow and there are two green arrows. What are they? I'm going to give you just a second to think about it and come up with the best answer to that question. What is the best answer to that question? There's actually two answers to the question, two different ways to phrase it, if you will. What specifically? And the key to the diagnosis lies in knowing exactly what these are. I am not kidding. It's beautiful. Okay, if you said pineal calcifications, your grade is 50, okay? And 50 is an F, all right, in the English system, so you get an F. But it's a high F, okay? It's not a 0, so that's good. One of these is a pineal or pineal stalk calcification. The others are not. The others are not pineal calcifications. That's why you get a 50. That's why you get an F. Now, I know that some of you, maybe from Europe, I'm not sure, maybe Canada, if you attended a progressive school that did not believe in the use of the grade F or fail, no one got an F, right? It's bad. It's bad for the ego. It's bad for the child, etc. Then I want to congratulate you on your participation trophy for your performance in this conference. Congratulations. Yeah, pineal calcifications. You're a winner. You can pick up your trophy when the COVID-19 crisis is over. Okay, do you like that sarcasm? All right. And I would say to you, if you're happy with pineal calcifications for this, good luck in the real world. Seriously, that's not the level that we expect in the Texas Medical Center. That's not the level we expect. We raise the bar, and this case is a beautiful example. All right, what specifically are indicated by the arrows? First of all, this one. All right, that is the pineal gland and or the pineal stalk. Sometimes you can see them separate, sometimes they're fused. All right, what are these guys? These are the two key structures. These are the key to the case. Magnificent. Anyone that's not familiar with the case want to chime in? I'm afraid most of our experts attending the conference are familiar with the case. All right, but hopefully you'll never forget it. All right, why? Why am I saying that these are the key to the case? All right, because look at the relationship of the mass with respect to them. All right, we're going to get there. I just put a dot in basically the epicenter of the mass, the center of the mass. All right, and let's do a little neuroanatomy. The double asterisk, that's the third ventricle. Probably know that. Single asterisk, fourth ventricle. All right, here we go. What connects the third ventricle to the fourth ventricle? Cerebral aqueduct. This is essentially close to a midline cut. It would be right here. It's not there. I can tell you couldn't see it. If you were to scroll the sagittal, parasagittal cuts, you would not see it. It's not there, but there's the connection. All right. Here's the point. The point is that the cerebral aqueduct is below the lesion, or the lesion is superior to it. Okay. What is this structure? That structure is not part of the mass. What is that? Notice it is posterior and above the aqueduct. That's the inferior collicula. So we have the colliculi. So now we are localizing, we are precisely localizing the mass. All right, have another look. All right, putting it all together. All right, here's another question. What structure, what curvilinear structure are the arrows indicating? Which it's like a rainbow. It's like a rainbow. And you know what the pot of gold at the end of the rainbow is? It's those two little dots. Sometimes in this particular cut, usually you see the two dots on an axial and coronal. Axial and coronal, typically you don't see them on sagittal. That's okay. It could be a single dot. If it's a single dot, the principle is the same. The pot of gold at the end of the rainbow in terms of diagnosis are these dots. All right, this is the habenula. Habenula runs along the thalamus, the thalami, one on either side, like reins of a horse. You know, horse and carriage, the reins are just riding a horse, horseback. You have two reins, one, rein, one in each hand. That's what habenula means etymologically. The habenulae terminate in the habenular nuclei, and there's a commissure which runs between the two habenular nuclei. So you could call these habenular nuclei, habenular commissure, or we could call it the habenular complex, if you will, right? Okay, so the best answer to my question, what specifically are these hyperdense calcifications? The best answer would be, well, the larger one is the pineal gland / pineal stalk calcification, and the smaller dotted dots are in the habenular nuclei, or the habenular commissure. Or is there a term for all of them that would be accurate? Pineal calcifications we know is too specific. Yeah, it's physiologic calcification, the epithalamus, epithalamic calcifications, because the epithalamus is not synonymous with pineal gland. The pineal is the 800-pound gorilla. Actually, that's a pretty big gorilla, isn't it? Maybe we'll say 400-pound. That might be realistic for a gorilla. Yeah, it's the big guy, but the habenular nuclei are also part of the epithalamus, right? As is the habenular commissure, right? So we can call all of that the epithalamus. So this is physiologic calcification epithalamus. These are landmarks for us. Okay, all right, let's put it all together. Here's the point. The mass lies in the posterior third ventricle, right? Because you can see it's bulging into the posterior third. That's very important. The posterior third ventricle overlaps with the quadrigeminal cistern and with the pineal gland and its attachment, and all of that together is the, quote, pineal region. So pineal region includes the pineal gland itself and the posterior third ventricle in front of it or anterior to it, and the quadrigeminal cistern and vela interpostum posterior to it. All right. The mass lies superior to the cerebral aqueduct, anterior to the colliculi, and critically inferior to the habenular complex. All right, you got it? That is the precise localization, which is really facilitated by seeing those habenular calcifications pushed dorsal and posterior. All right. Question. What neuroanatomic structure lies in the anatomic vicinity of the epicenter of this mass? We've placed it. It's going to be above the aqueducts and be anterior to the colliculi. It's going to be below the habenula. What is the answer to that question? What neuroanatomic structure, which likely is giving rise to this mass? Now, there's always a differential. It doesn't have to be, but if you see a mass in this exact location with essentially no involvement of the pineal gland, anterior pushing the habenula posterior like that, you're not going to say pineal parenchymal tumor, germinoma, yada, yada, yada. You could put those on your list. It's possible, but they're lower down. What goes number one on your list? What is number one on your list? What is the anatomic structure? And the answer is, give a minute for anybody who wants to type. I couldn't type. It's probably take me 10 minutes to type it. So I don't blame anyone for not guessing, okay? The vestigial remnant of the subcommissural organ. Now, vestigial remnant means that it is no longer producing a Reissner's fiber as it does in the embryo. In the human embryo, subcommissural organ secretes a Reissner's fiber. That's an eponym. You can look up Reissner, look up the Reissner's fiber. I think I have it maybe in histology for pathologists, all right? It's vestigial, but it's still there. It's modified ependymum, all right? So let's take a quick, it's one of the circumventricular organs. Shall we take just a very quick review of the CVOs? Yeah, here they are. The pineal gland, the median eminence infundibulum and neurohypophysis as a complex, the subfornical organ, the OVLT, organum vasculosum of the lamina terminalis, the area postrema, which is the only paired, one on either side, floor of the caudal fourth ventricle, the chemoreceptor trigger zone for emesis, and the subcommissural organ, which is vestigial but present. How do I know that it's present in humans? Well, it's in histology for pathologists. 5th edition, Fuller and Ballister. Here we go. Here's a CVO illustration. This was actually in the very first edition. We carried it forward here, all the CVOs, and showing histology of all of them except for the area postrema, which would be very easy to get. Let's look at, this is a nice this autopsy midline section. And there you can see the OVLT, all right, anteriorly, all right, there's a lamina terminalis. It's located there typically in the lower part of the lamina terminalis, just above the hypothalamus. and sella turcica. Subfornical organ is in the very bottom of the fornix, just before it becomes the anterior columns of the fornix in the foramen Moreau region. There's the pineal gland in the rear here. Then the subcommissural organ. What you're actually looking at, that backwards C is the posterior commissure, and the subcommissural organ is modified ependymum epithelium on the surface of the posterior commissure. And then here, yeah, there was the median eminence. Okay. In the mouse, the subcommissural organ is magnificent. So look at the bottom part. This is the normal ependymum of the third ventricle, rostral third ventricle, and look how it blossoms dorsally. Is that magnificent or what? Oh, that's something. In the human, it is identifiable, check it out, as a vestigial remnant. Now the question, now you've seen the histology of the human vestigial SCO. How cool is that? I bet many of you had never seen human subcommissural organ. All right, why are we talking about this? What is the clinical application of knowing the CVOs? Is it just neuroanatomy minutia? No, of course not. We wouldn't be talking about it in this conference if it was. Tumors are associated with every single one of the CVOs. All right, you want to take just a second? I'll let you look at the list. Okay, pineal gland, that's going to be obvious. That's the pineal parenchymal tumors, right? Which would be pineocytoma, pineal parenchymal tumor intermediate differentiation, PPTID, and pineoblastoma. Neurohypophysis, which one is that? What is right? Pituocytoma. Yeah, good. Dr. Harb got that one in. Dr. Harb's a very good fast typist. The OVLT, which one? Which tumor is associated with the organum vasculosum of the lamina terminalis? Which one? Which one? Okay, and then, yes, chordoid, that's good enough, Dr. Hard, chordoid glioma. And then finally, the SCO, which is what our tumor is, the PTPR, papillary tumor of the pineal region. The imaging in this case is perfect for papillary tumor of the pineal region. All right, let's look at that anatomy closely. I've labeled here the habenular complex. You see the pineal gland, PG, underneath the splenium. Splenium of the corpus callosum, pineal gland. Habenula would be at the superior attachment of the pineal stalk. The inferior attachment blends into the posterior commissure, and the subcommissural organ is on the surface of the posterior commissure, right at the additus, the opening of the cerebral aqueduct. All right, keep that in mind. All right, so that's the region we're talking about. All right, what the arrow indicates, all right, on this mid-sagittal MR section, that is the posterior commissure, hence the location of the vestigial CVO. And guess what I'm going to show you next? I'm going to show you from the literature a small tumor right at that point. All right, how about that? This is one of the smallest examples of a PTPR you will see. It exquisitely localizes it to the region of the posterior commissure vestigial subcommissural organ. Would you like to see another one? There's another one. All right, MD Anderson case. Very small. The smaller tumors exquisitely localize the tumor. How about from the literature? Look at this case from Nakano and colleagues, neurosurgery, 1997. Papillary tumor of the pineal region. Small tumor provides exquisite anatomic origin localization. Can everyone see with the black arrow on the left, tiny little dot, and on the right? How magnificent is that? Just like our examples. Okay, what about the older literature? You know, we haven't always known. Listen, we haven't always known about the existence of papillary tumor of the pineal region. They have been resected and identified long before we recognized what they were, and they were misdiagnosed as all kinds of things based on their histology. One of the misdiagnoses was ependymoma, and guess what? Listen to this. You're going to love this. There is an entity in the literature called papillary ependymoma of the cerebral aqueduct. And here's a case report from 2009, papillary ependymoma degree 2 of the aqueduct treated with endoscopic tumor resection. All right, here's the histology. All right, and look at the arrows. Again, the arrow here, the arrow is actually on the splenium. Here is the inferior colliculus, superior colliculus. This right here would be posterior commissure. There's the little tumor. And if you look over here on the right, on the T2, can you see the obstruction right at the opening, the additus, the cerebral aqueduct? Isn't that a cool example? But wait, it gets better. There, I've circled them. I circled them for those who maybe my arrow wasn't clear. Look at that. Okay, and this is a pre-op on the left, just magnified, showing the tumor. in the location, and look at the post-op. It was simply resected endoscopically, and now you have a beautiful open cerebral aqueduct and relief of the obstructive hydrocephalus. But wait, it gets even better than that. How about endoscopic photograph? Would you like to see that? Here we go. On the left, before resection, there it is. Right at the opening of the aqueduct. Aqueduct would be going posterior to the tumor. The tumor is blocking our view of the aqueduct in the middle. All right, as we are resecting it, as the neurosurgeon is resecting it, just the attachment right here left, a little bit of blood, open aqueduct. How cool is that? What conference are you going to go to be able to see this, to be able to see it all laid out? I don't know of another one. All right, there it is in all of its glory. Here's the point. Is this image pathognomonic, absolutely specific for PTPR? Of course not. There's always a differential, but it has to be high on your list. Maybe number one on your list if there's another feature present, which I'm going to get to in just a second on the MR. But I wanted to spend all this time with the CT to show you how important the CT is. You know, for many functions, for many applications, CT is far superior to MR. And you say, well, it doesn't have the resolution. Well, neither does PET. And look at the thing that infused PET CT can do, right? Okay, let's look at the histology in our case, all right? Because we're going to show pathology too. This is smear preparation of PTPR. You can see the blood vessel in the center. Tumor loves the blood vessel. Here we go. It also is kind of showering out. This is my smear. It's pretty good if I do say so myself. I'm going to pat myself on the back. I'm just stating facts, okay? It's a nice smear. How about that? All right, if you're a pathologist, that really should take your breath away. The quality of this smear of papillary tumor of the pineal region, there are the little rosettes. That is stunning. This in connection with imaging, man, that would do it. All right, here's a little pleomorphism. You can see some of the cells have a little bit of eosinophilic globular cytoplasm. There's some rosette formation. You see a little anisonucleosis, variation in size of the nuclei. All right, that was the cytology prep. Here's the FFPE, formless paraffin embedded. Again, look, can you see the rosettes? And then there's sheets. Look at the vessel here and see the little processes like perivascular pseudorosettes. That's why it was called, misdiagnosed as ependymoma for the longest time, or sometimes choroid plexus papilloma, all right, because of the choroid plexus, the third ventricle, right? Also misdiagnosed as that. There's another example of the vessel. And that's why, remember on the smear, how the cells were clinging to the vessels, the ones that weren't in sheets and getting smeared out? This reflects exactly what they're doing. All right, very characteristic immunophenotype of PTPR. Two markers are the hallmark. And we'll look at things that are positive. Two markers, keratins, particularly keratin 18. That's the one. Some places like Anderson, we run 818, keratin 818. Keratin 18. It can be 4+ strong like this, or it can be only focally positive at the pseudorosettes, sort of like GFAP and ependymomas, or frequently they can be 4+ strong everywhere, or they can be stronger at the pseudorosettes. Same thing with keratin 18. This is a marker you will want to run as a pathologist if you suspect PTPR. And then NCAM, neural cell adhesion molecule, or CD56. Again, usually strongly positive like this. That's a pretty cool combination. All right, keratin 18 or CK18 and NCAM, CD56. All right. Also, PTPRs, they do express S100 protein. That's another marker you can run. Vimentin, usually diffuse expression for sure. Neuron-specific enolase, MAP2, transthyretin, they can express. Weak, focal, or absent GFAP. Maybe some weak focal, but not like you see in ependymoma. You will not see the strong perivascular staining or diffuse as an ependymoma. Dot-like EMA, like you can see in rings in ependymoma, is usually not seen or very weak, faint focal. Synaptophysin, chromogranin, no, maybe weak, focal, not convincing, virtually never neurofilament protein. All right, molecular signature, PTPR, chromosomal alterations, loss of 10, including alterations of P10/MMAC, gains on chromosome 4 and chromosome 9. DNA methylation profiling separates PTPRs into two distinct clusters. All right, cluster A, cluster B. That'd be MC, methylation class, methylation class 1 and class 2 of PTPR. And DNA methylation profiling also clearly separates PTPR from ependymoma and from choroid plexus papilloma, which are the two main misdiagnoses in the past. So someone might make the argument, well, I think PTPR is just a type of ependymoma, et cetera, et cetera. They really are distinct. They're distinct enough to be separate. All right, maybe related, closely related. We're hypothesizing they come from modified ependymoma, right, of the remnant subcommissural organ. All right, behavior of PTPR. Temperature grade 2 or 3, typically grade 2, local recurrence, could be a 3. Criteria for distinction not established, prone to local recurrence, as I said. CSF dissemination can occur. Histologic predictors of short and progressive free survival and overall survival. Greater than equal to 3 mitoses per 10 high power fields on H&E. Ki-67 of 10% or higher. That's in two fairly good studies, 20, 30 cases each in the literature. Okay, I mentioned that I wanted to address, and we got about 5 minutes left. I wanted to address I think I should show you the MR of our, this is the present case, all right? I showed all the CT, here it is, sagittal section, T1 post-contrast, homogeneous contrast, that's very typical. See the classic anatomic location like we talked about. That's not what I want to discuss though in the last minute. And that is, this is the T1 without contrast. And what you can see is intrinsic T1 hyperintensity. All right, you can certainly speculate, could that be blood? It could be. Could it be melanin? All right, a melanotic tumor, or melanotic, it could. Calcium can under certain conditions be hyperintense. So intrinsic T1 hyperintensity is a characteristic feature of some, maybe many PTPRs, not all. It's sort of like the T2 flare mismatch sign. When it's present, and if you can eliminate melanin and hemorrhage by looking at CT and gradient echo and all of that, then it can be very informative when it's present. All right, who described that, by the way? It's in the WHO. Oh, well, let's go to the American Journal of Neuroradiology, 2008. Oh yeah, I forgot it was me. So that's not really entirely true. In fact, I'm going to relate the story to you. So here's the PDF, MR imaging of papillary tumor of the Pioneer region, 2008. Chang, Fuller, Debnam, another outstanding MD Anderson Cancer Center neuroradiologist, Karis, Steve Coons, neuropathologist at the Barrow, Ross, and Dean, superb radiologist there at the Barrow. All right, from the paper, look at this, 3 different patients, T1 without contrast, showing this intrinsic T1 hyperintensity. There's the histology, very similar to what I have shown you. In some cases, it actually will be papillary, that's the upper left, etc. That is, keratin in the upper right. Let's read the conclusion. Our findings suggest that intrinsic T1 hyperintensity may be characteristic imaging appearance for PTPR. In the imaging absence of fat, hemorrhage, melanin, or calcification in a mass of the posterior commissure or pineal region, the diagnosis of PTPR may be suggested so that specific immunohistochemical studies can be performed for a definitive diagnosis. Now, that is a very modest, very accurate statement. It's not saying it's pathognomonic. It is not present in all cases. I look for it in every case that comes through. It's saying if it is present and if you can rule out to a greater extent using other imaging modalities that it's likely not to be one of these other substances which are intrinsically T1 hyperintense, and if it's in this anatomic location, as in our case, it's like, man, the first 10 things in your differential diagnosis are going to be PTPR. All right, I told you I'd tell you the story. So you could think of this T1, intrinsic T1 hyperintensity of PTPR. I'm going to call it a co-discovery of the Barrow and MD Anderson. So here's the author affiliations from the divisions of neuroradiology and neuropathology. That's Steve Coons, the legendary Steve Coons, I believe now retired, Barrow Neurological Institute and the Department of Pathology, section of neuropathology, me, and radiology, Dr. Debnam, MD Anderson Cancer Center. All right, here's how it went down. There's Dr. Coons, underline myself. Basically, I got an email. I can't remember if it was an email, telephone call. Dr. Coons, a lot of times like to use the telephone rather than email. I had a call from Dr. Coons. He says, listen, neuroradiologists here think they have an imaging sign that's characteristic of PTPR. Do you have any cases? Could you look at them and see if you have the sign that's intrinsic T1 hyperintensity? So I go through the cases. I go through my files. I do, in fact, find 1, 2, I can't remember, number of cases that did. You know, I call him back and said, yeah, I have them. And he said, okay, let's put them all together. I thought it would be very good. It would be very collegial to include a neuroradiologist, duh. So I invite Dr. Debnam. Now, Dr. Debnam and I had just finished editing a series of papers in the Archives of Pathology and Laboratory Medicine on imaging in brain tumors, and I had tapped Dr. Debnam to write the imaging paper for that collection of papers. And so it was just about the same time that this came along, and Dr. Debnam agreed to help me and said, sure, I will check, the imaging, the yada, yada, yada. And now you know the rest of the story. Stuff like that, the little bits and pieces, because you can look at this and you can think, how the heck did Fuller, a neuropathologist, end up as the second author, right? And I don't know if I think a AJNR used to be, maybe it's still the same, many of the radiology journals. And if you look at the references, it's the first three authors, and then they do the first three. They may have changed, I don't know, but I know back in the day that's the way it was. So I had it said to me more than once, and I've authored many papers with our neuroradiologists. I've had them say, you know what, if you want to be the last author, senior author, I'll take position number 3, because what you see in that reference list is Chang, Fuller, Debnam. So that's a pretty cool thing. But now you know the story. This little minutia stuff like that, you only get that, normally you get it at meetings, right? Over coffee at the meetings, and that's the importance of getting to know people. Okay, it's 1 minute after the hour. I'm gonna close the conference with the big news of the week, all right? And this is something I said, I didn't know how often there'd be big news of the week. There actually is big news. There's bigger news coming, but how about this? I have a little big news of the week, and I'm gonna put it in the form of a question. What important deadline falls at midnight tonight, local time? Whose local time? Your local time, my local time. Local time all over the world on this day, all right, July 24th. What deadline is it? It's almost like a riddle, The reason why and that's going to, it varies local time, is because the authors live all over the world, and the deadline was to have the drafts of the chapters of the 5th edition of the World Health Organization submitted, uploaded to the website so that they can be vetted by the senior authors and editors. Now, all this means, we're still a ways off from publication. What it means is the WHO 2020, the 5th edition, fully revised, new edition, it's coming. And it's going to be a lot of fun, and we will address all of the changes in this venue. Well, I think that's all I have. I want to thank everyone for attending. Without you, there wouldn't be a conference. Thank you so much. I am on service next week. We may have to cancel the conference, or I may move it to 7 a.m., something like that, because the Frozen's, right? I can't do it. I can't ask one of my colleagues to cover. So you'll get a notice one way or the other. Thank you so much. And that concludes today's presentation. Bye.